Hello, and welcome to the University of Washington Cardiometabolic Echo Session 12. I'm Nicole Earhart, one of the adult endocrinologists here at the University of Washington Diabetes Institute. And today we're excited to have our keynote speaker, Christos Argyropoulos, who's coming to us from New Mexico and is an adult nephrologist. And he's going to be talking to us today about new and breaking literature on obesity, renal, and diabetes medications. Additionally, we have a great set of panelists today, including Savitha Subramanian, who is our adult endocrinologist here at the Diabetes Institute and our resident lipid expert. We have Allison Ward, who is our clinical psychologist and an expert on diabetes and distress. We have Allison Brunner, who is our certified diabetes educator. We also have Portia Hong, who is our clinical pharmacist. And we also have Catherine Davis Scott, who is our social worker here at the University of Washington. And then we have Nyan Arora, who's an adult nephrologist, also here at the University of Washington. And finally, we're really excited to welcome as our patient voice and part of our Diabetes Echo Action Collaborative, Fernando, our patient voice today.
Well, my name is Fernando. Live with diabetes sometimes has been hard for me. Being from Spain, we love cakes, we love all the things that you don't need to eat, bread, etc. But I have been managed my diabetes with the Dr. Wright, and I feel very comfortable with the levels and the way they have been treating. The only I miss more is our Spanish food. I need to reduce the size. I need to eat less what I like, and practically that's what I have been. Have been very easy for me. My wife is also diabetic for more than 50 years. She's type 1, and she has been controlling me because before the diabetes, nobody can control me.
And thanks for sharing that information and those great points about how you help manage your diabetes with your lifestyle and portion control. And then also having a support system is always important for diabetes. The next question I have for you is, my understanding is you were told you had an early marker of renal disease. How did you feel when you were told that you had some indication of early renal disease?
The beginning, Dr. Rice said that I have a little proteins in the urine, and that's scared. For there, I started the problem with the kidneys. And she controlled me with pills. I don't remember what is the name of the pills. Lisinopril. Yes, I thought she know more than me. And the lisinopril have been control my proteins through the urine.
Thank you. And then my final question is, if you were able to share with your healthcare team, what was one or two main things that helped you most with managing your diabetes?
First, I started with another doctor with my diabetes, but when I changed to Dr. Wright she's Mexican. She understands the Latin culture. And in base of that, it's easy for her to explain to me in simple words what and why. Because something that I noticed here in the doctors in the United States, you have your field, but my field is different than your field. Maybe I started to talking about computers and you don't know nothing. The same happened to me when they started to talk about medicine and use the medical term like PD and HD, and what means that? For me, don't mean nothing. We need a certain explanation. Some doctor doesn't have the time, maybe because they need to accomplish so many patients in so little time. That's something that in Europe, you don't see that in Spain. You don't see that in South America. If a doctor is with you, could be half an hour, could be 2 hours, until you understand where you are and what you need. That here is different. Here is ping, 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 bye.
And that's a great point. I know when we first had our conversation, I'm a fast talker. And so I was reminded how to best talk. And so it's always great to hear what is most beneficial. And it sounds like really working on our language and explanations will really help patients living with diabetes. So thank you for answering those questions. And now we're going to turn it over to Christos. Go ahead and share your screen and take it away for our didactic today.
Thank you, everybody. All right, these are my disclosures. One of the disclosures with Otsuka has ended. The other three are active. The learning objectives for today is to discuss pharmacological interventions that reduce the risk of kidney and heart complications in patients with diabetes. And the second objective is how to select these patients, these new therapies, and how we reduce their high cardiorenal risk. I don't have to remind this audience that diabetic kidney disease, which we abbreviate as DKD, or more recently as diabetes in chronic kidney disease, is actually a fairly common condition. And it's not getting less infrequent with time. These are data from the NHANES, the longitudinal survey that's been going on in the US for decades, that show that over time we have had an increased prevalence or increased frequency of conditions like an elevated BMI, high blood pressure, diabetes, and hypertension. And the proportion of people with markers of decreased kidney function, the test that we now know as eGFR, or evidence of kidney damage, which is assessed by measuring the protein in the urine, has also been increasing over the last few years. There is some minor exception or minor win to that rule, which is specific to the patients with diabetes that I'd like to highlight. So if you take a journey back in time, the year I went into training really, which was 99, we had about 35% of patients with diabetes who had normal protein in the urine. And this percentage is a little bit lower nowadays. And this is like a minor win that's due to medications like lisinopril, but unfortunately does not change the picture that over time we are seeing more and more people with depressed kidney function. And depressed kidney function, when it progresses, leads to the need for dialysis. From a public health, but an individual health perspective, we care about co-occurrence of diabetes and hypertension because of the simple equation I put up in the top of the slide, that if you have diabetes and kidney disease, and some other form of cardiovascular disease, then you're more likely to have increasing rates of hospitalizations and increasing rate of death. There is obviously a dose-response relationship in that the lower the kidney function, and we'll talk about how we stage the kidney function the next couple of slides, the higher the chances of needing a hospitalization or dying. So these factors, diabetes, chronic kidney disease, and cardiovascular disease, are intimately related, and the focus of our practice should be to manage both and manage it successfully. So from a population perspective, we take a global view. We have nearly 500 million people living with diabetes nowadays. Most of it is going to be type 2 diabetes. Out of these individuals, about 4 in 10 with type 2 diabetes and 3 in 10 in type 1 diabetes will develop some form of chronic kidney disease. The majority of these people will actually not progress to need dialysis. Only 1 in 10 will eventually require this therapy. The reason for that is not some kind of great success in medicine. It's because about 9 out of 10 with diabetes and kidney disease will die before they require dialysis. So we have this situation in which the people within our dialysis units are really the tip of the iceberg. And the majority of the patients who have these two conditions, diabetes and chronic kidney disease, will not progress to dialysis because they will die before they need it. So it's really our approach to this disease has to take into account both cardiac, both heart and kidney specific outcomes. How do we diagnose diabetic kidney disease and how we assess the risks for patients to develop these complications? Actually, this is fairly simple, and it's one of the If you are to retain one thing out of this presentation, is how simple it is to actually do this risk stratification and select patients for further intervention. So nephrology, my field, can be kind of daunting or not, but in terms of diagnosis, we only need two tests. We need a test of kidney function, which is the test we call GFR. It's based on a mathematical transformation of the creatinine level. And we need a test of kidney damage, which is the albuminuria, which we can measure in a spot sample. We don't need things like collections. And we compute the ratio of albumin to creatinine. These two tests give us the information we need to classify patients in terms of how depressed, reduced their kidney function is, and how high the evidence for kidney damage is. And both of these tests need to be obtained in clinical practice. And in fact, they are part of the annual screening standards for diabetic kidney disease for both type 1 and type 2 diabetes. But we often forget to order them both at the same time. The reason that we need to obtain both is because there's been a lot of evidence that both tests individually and in combination can allow somebody to predict who is more likely to need dialysis and who's also more likely to develop a heart-related complication. So I like to tell people that when you obtain these two tests, you're effectively obtaining a kidney-specific cholesterol. And you can see in this graph, which uses a color coding to communicate the risk for things like need for dialysis, heart attacks, cardiovascular death, that either depressed kidney function or elevated protein in the urine or both are associated with bad clinical outcomes. So this is really a reasonably simple and straightforward test you can do or you can order to predict who of your patients will need additional therapies and how they should be managed. Now, going back in time, in 2003, this was one of the first studies that actually looked at what happens to patients who are on medications like lisinopril or losartan. So this is a secondary analysis of the Renal trial that led to the approval of losartan as a medication for diabetic kidney disease. And what the authors found is that if you take the patients in the study and after they have been placed in the medication and look at the amount of protein in the urine, if this continued to remain elevated, the patients were at higher risk for losing further kidney function, which on the table that you see on the screen is given by doubling of serum creatinine or need dialysis, what we call end-stage kidney disease. And it's kind of interesting that if the importance of this factor held across the board, irrespective of race, gender, or ethnicity, or even in combination. So it's a really powerful predictor of who is likely to suffer additional kidney damage. Again, the study, that particular paper sort of look at what happens to patients whose albumin in the urine declines or not after they start losartan. Obviously, patients who responded with a reduction in the albumin in the urine had better outcomes. They kept their kidneys functioning for longer than patients whose albumin did not go down after they started losartan, or those whose albumin in the urine declined somewhat more moderately. This is one of the reasons why you're going to see many nephrologists actually measuring the protein in the urine after they put patients on therapies, because if patients don't respond, then we know we're dealing with someone who's very high risk, who may need extra attention and care to prevent both heart and kidney disease complications down the road. Again, the previous slide presented the data about chronic kidney disease. Now, this is a more global slide that looks at protein in the urine as predictor of overall death, need for dialysis, and cardiovascular events. And you can see it's the same dose response curve. People who put on one of the medications like lisinopril or losartan, who have no protein in the urine have the lowest risk. But if they have elevated protein in the urine after you put them on the medication, their risk remains elevated. And this is particularly important in patients with diabetes. Patients with diabetes, whom form the majority of the patient size in clinic, really need special attention to their albuminuria measurements. Now, about 6 or 7 months ago, a work group at the American Society of Nephrology put together a commentary on the most recently released guidelines, which attempt to give a very holistic approach on how we manage patients with diabetes. So it's an open access paper that you can download, but the essence is summarized into this picture here. So it includes things like glycemic control. It includes things like smoking cessation, nutrition. But the group itself realized that one of the major wins in the last 2 years has been the introduction of new therapies, medications like the sodium glucose transporter 2 inhibitors, the GLP-1 receptor agonists, and more recently, the non-steroidal mineralocorticoid antagonist like finerenone. So although we do take a holistic view, we should acknowledge that a major victory or series of victories has been clinical trials that showing that these medications really work. And I like to spend the remaining of the presentation talking about these therapies. These are a few of the citations in my work in the area. About 1.5 years ago, having been fed up with denials from pharmaceutical companies, one of my primary care colleagues from Ohio, Dr. Mike Johansson, and myself said, screw this, let's do a meta-analysis and cite our paper on prior authorization. So some of the figures you're gonna see is from a paper I did with Mike, which was really intended to give ourselves a citation when we're dealing with insurance companies. So some of the graphs you're gonna see here. So this is the snapshot of the trials that have involved patients with diabetes, with or without kidney disease, with the SGLT2 inhibitors. There's been more trials since that meta-analysis with the SGLT2s, but there's been mostly trials in heart failure, so they are not really included here, although I will speak about the results later. So these are all the studies combined, and the message is very simple. You use an SGLT2, you can reduce all-cause and cardiovascular death by 15%. So this works on the 90% of patients with diabetic kidney disease who never reach dialysis. We can reduce their risk, and this is a very similar risk reductions to other heart protective interventions that we have at our disposal. When we look at cardiovascular events or heart failure, and cardiovascular events include things like heart attacks, need for stents, the SGLT2 inhibitors will reduce the risk for those events by 10% and heart failure by 1/3. Like this, these data are really unmatched by almost anything we had at our disposal. So you have a drug that will do like 5 or 6 things at the same time. Never had anything like this in any of the areas of medicine. More relevant to kidney disease, and this is why SGLT2s are now prescribed by nephrologists. You can reduce the risk for dialysis or risk for worsening kidney function by almost 40%, 35 to 40%. So this is why nephrologists like ourselves love these drugs. There's been some discussion whether these findings or benefits are class versus drug specific. If you resort to statistical analysis, you'll find that there is very little heterogeneity. There is some noise in the trials, and so it's more likely that these are class effects as opposed to drug-specific effects. Having said that, there are FDA works on the specific agents, so different SGLT2s have different indications for diabetic disease, non-diabetic kidney disease, heart failure, and so on and so forth. We have seen these benefits across demographics, across level of kidney function. So effectively, these analyses, and even irrespective from the presence of diabetes, kind of say they just put SGLT2 on the water. And it's a very easy therapy to use. No need to escalate the dose when you use it for cardiorenal protection. So these are the adverse events that were observed in the study. So we had things some people are concerned about, The most definite signal is for events like diabetic ketoacidosis. That's increased about 2.6 to 2.8 times on SGLT2 inhibitors. Other events such as genital mycotic infections, which are not UTIs, they're just like yeast infections, they go up at the same amount. There are some other complications that were seen early on in the development program of these drugs, but they are so uncertain that they are on the label, but for the most part, we don't tend to see them. The other benefit of the SGLT2s, and this is when you're discussing the initiation of these therapies with the agents, you tell patients that it may help drop your blood pressure somewhat by 4 points. So that may save you like a blood pressure medication. You may lose about 3 or 4 pounds of weight. And these are like things we use in practice to communicate with patients. The two studies that were reported actually the last 6 weeks are trials with SGLT2s in heart failure. I'm just including them there just to communicate the final message that these drugs work across the board, irrespective of diabetes, irrespective of whether you have heart failure or not. And it shows that these agents do reduce the risk for hospitalizations for heart failure. So effectively, it's a single class of drugs with multiple benefits. So we tend to use them. As I mentioned, one of the biomarkers we use to predict or figure out who needs additional therapy is measurements of protein in the urine. So about 2 years ago, there was a meta-analysis by Cochrane which tried to quantify that and asked the question, what can we do in these patients? So this meta-analysis used very old drugs like spironolactone, and concluded that you may see some benefit in terms of the reduced kidney failure or death, but the data were too little, too variable to call it with certainty. However, this provides some evidence that this class of medication may offer benefit. This hypothesis was actually put into test in 2 large randomized trials with a non-steroidal MRA called finerenone. The 2 studies are Fidelio CKD, and were put together in meta-analysis called Fidelity. So that was a pre-specified meta-analysis that the FDA requested to combine the 2 large trial that included thousands of patients. So it kind of showed that finerenone reduces the risk for cardiovascular disease by about 14%, heart failure by almost 22%, and kidney disease by 23%, and dialysis by 20%. So this is really on patients who are receiving ACE inhibitors or ARB, have elevated protein in the urine. Finerenone delivers additional benefit. So what about the GLP-1s? The GLP-1s is a very interesting class of drugs. I probably don't need to lecture this audience how to use them. I often get lectured on how to use them in the clinic. But the studies that led to the approval of the GLP-1s also had measurements of kidney-specific tests, like the proteinuria. So when you look at what happened in those studies, obviously they reduce, or most of them reduce, the risk of major adverse cardiovascular events. So this is one of the reasons that we use them in practice. But when you look at protein markers like the proteinuria, you can see a consistent effect of the GLP-1s in reducing markers of kidney damage. So we don't have any kidney-specific outcome studies like the SGLT2s yet, but from the data that's available now, it seems that these agents may also offer some kidney-specific protection. And this is why one of the reasons that they are preferred in guidelines for patients with pre-existing cardiovascular disease, and you may see your nephrologist actually recommending it or making a suggestion in the chart when they're sending the referral recommendations back to you. Interestingly enough, the GLP-1, GIP-1 dual agonist may also have a similar event. This was an abstract that was presented in the summer from the clinical trial SURPASS-4 of tirzepatide. And again, these were not kidney-specific trials. It was just like a weight loss trial, but they look at tirzepatide and they found that it can also reduce the markers of kidney damage in the urine. So this is also another class of drugs that very likely will be associated with kidney benefit in terms of reducing need for dialysis down the road. So after bombarding you with data, and if you're only have to retain one thing or a few points after the presentation, the points that you can retain are the following. So if you see patients in the clinic, you can decide who needs further therapies by measuring the protein in the urine. You should be doing that anyways, but if you don't, and the patients ask you the question, do I need further therapies for my heart and the kidneys? Yeah, there are things like cholesterol that you should measure, but there is the kidney cholesterol, the urine albumin, protein in the urine, very simple measurement, and it can tell you exactly who are the patients who need further therapy. The SGLT2 inhibitors are the class of agents that to this date know have a very broad cardiovascular and kidney-specific benefit. They reduce heart failure, reduce death, reduce cardiac events, reduce the need for dialysis. And these benefits are likely to be class rather than agent-specific. Having said that, not all agents have been put into the same test. So if you are trying to be evidence-based, then you really need to be using agents out of the SGLT2 class that have had heart-specific trials and kidney-specific trials. The effects of the SGLT2 don't differ if somebody has diabetes and not diabetes. The selective MRAs, which is only one medication, finerenone in the United States, seem to have the same effects on heart and kidney-specific outcomes as the SGLT2s. So you will be seeing them more and more of them be used by nephrologists and even primary care doctors for their patients. What we tell our patients in the diabetes clinic we run for our transplant program is we would like for you to stop associating the letter G with glypizide and associate it with one of the GLP-1s. Really, we run our own diabetes management clinic in our transplant program, and we literally get rid of glypizide and put one of the other. So stop G doesn't stand for glypizide. The open question, and this is a question it's going to be answered by a couple of clinical trials that are ongoing, is whether you should be putting your patients on all three of the agents. They all should be on an ACE inhibitor or an ARB if they can tolerate it. But how do you stage the additional agents? Remember, none of the trials for SGLT2s, they never included finerenone. Finerenone was an experimental drug when these trials were being done. The GLP-1 trials didn't include SGLT2s for various reasons. So we really don't have a lot of evidence how combined therapies work. There are some secondary analyses that show that you don't nullify the protective effect of one drug by combining it with another. And there are also animal studies that suggest that it's better to have patients on, all two of them. Any of the two combinations, really, nobody has tested three of them. But if you're asking for trials for combination, you don't have any. In my practice, I stick by the rule of the proteinuria. So, if a patient comes in on an SGLT2, I measure the protein in the urine, they're elevated, they go on finerenone. They come on a GLP-1, measure the protein in the urine, and depending on other things, they go on an SGLT2 or finerenone. And then after a few months, there's another protein in the urine. If they're still proteinuric, they go on all three. Is there any specific evidence for this? Not really, but do know from many analysis that proteinuria is bad and all these therapies seem to reduce protein in the urine. So I don't think our patients have the luxury to wait for concrete evidence. The financial burden is not high, and we can monitor these agents in a clinical practice, which we can very safely, then might as well use them. So thank you for your attention. I hope I didn't go over too much.
Thank you, Christos, for those great discussion. And I loved your last slide about replacing the G. I think everyone's going to remember that clinical teaching pearl. And we as endocrinologists do agree with that as well. There is a question about, should we be using sodium glucose cotransporters outside of maximizing metformin first in the setting of CKD? Can you comment on that?
Yeah, that's a good question. So again, it goes back to what the clinical goals you're trying to achieve. SGLT2s, especially in the context of impaired GFR, are not the greatest sugar lowering medications. So, I mean, that's the reason why they were not really being used until those outcome trials came out. So, I mean, maybe you can get a 0.8 if your kidney function is normal. But once the kidney function declines, the A1C lowering is not the greatest. So if you have somebody with uncomplicated diabetes who doesn't have cardiac or kidney disease, the answer is actually maximize metformin. But if they have evidence of cardiac or kidney disease, the data for metformin in those areas are really not that great. So, are you treating a number? Or are you treating clinical syndrome? So in that case, the answer would be hit with the SGLT2 and then maximize metformin as needed.
And great point. And again, what we always highlight is a lot of these medications are outside of glycemic goals. So even if you're at your A1C goal for your individual, you're adding it for the renal and cardioprotective effects. The other question I wanted to ask you, because it always comes up, so canagliflozin and the risk for lower extremity amputation, particularly just the toe, but sometimes it keeps people from being on medications that are really beneficial. So as we heard from Fernando about talking to our patients, how do you talk to patients so they feel more comfortable with that blip that was seen?
So this is a great question. So just to give a historical background, the risk for amputations was seen in the CANVAS study, which was the cardiovascular safety studies for canagliflozin. It was also seen on the EMPA-REG study, which was the cardiovascular safety study for empagliflozin, and has never been seen in any study after that. The reason may be that after those studies were done, the clinical study protocols, especially for the canagliflozin, the CREDENCE study that looked at for the drug in chronic kidney disease, they excluded patients with active peripheral vascular disease. So if you have somebody with resting limb ischemia or with claudication at rest, I would not use an SGLT2 inhibitor there. I just have to be honest. Even it's a huge uncertainty, but if it happens, somebody will lose a toe. Having said that, if somebody has peripheral arterial disease that is controlled, been revascularized, they don't have symptoms. These are people who have extremely high cardiovascular risk. So in those patients, the answer is you use the SGLT2. So it's really active peripheral disease that I would refrain from using. And somebody who has had an amputation previously, and I've had patients like that. They don't have ischemia on their remaining limbs. They are on an SGLT2.
And this is like the shared decision making, right? Where you talk to them about it, but they're at high cardiovascular risk. And so you're helping them make a shared decision with you. So.
And again, this conversation was a little bit more relevant before finerenone and some of the GLPs, got approved, because now you can always say, I'll try something else. And if proteinuria persists, then you can have the shared decision making.
A great point that we have so many more options available, and that might be a good person to select the MRA in preferentially first over the sodium glucose cotransporter. So we could keep asking questions away, but I do want us to get to our case. So Jessica, would you mind starting our case presentation? Jessica will also help share the slides for you.
I'm Jessica Karp, a family med doc with OB at the Health Point Midway Clinic, which is down in Des Moines in the south end of Seattle. And apologies, there are some omissions to the case because it was done kind of at the last minute and I didn't have a chance to round back with the patient about stuff that I couldn't find in the chart. So this is a 40-year-old female who has diabetes. She has private insurance. She speaks English. She identifies as Hispanic or Latino. And I chose her because I saw her in clinic and her A1C was uncontrolled. And I thought, let's just see what help I can have. And as I was going through the case, I had a lot of different questions. So she really doesn't have a lot of comorbidities associated with her diabetes. And so I wanted to know, how quickly should we get her into control? What's the timeline for that, considering she's young and doesn't have retinopathy? Does that change how quickly we want to get her into control in terms of guidance there? And then there was one point where she was on aspirin. Maybe it was at the time when like everyone who has diabetes is supposed to be on aspirin. And then more recently, I think I calculated her ASCVD risk score and it was low. And so I stopped the aspirin and I wanted some input there. And then when would you kind of restart aspirin, or when would you recalculate to determine if aspirin's needed? I am considering weight loss medications for her. And I wonder, because she has no kind of contraindications, is there a preference between ephanthiramine, topiramate versus naltrexone, bupropion? If we were going to change mealtime, or if we were going to change insulin, would we add mealtime insulin, or would we do a mixed insulin? Those kinds of things. A question about glipizide. So I think she came in to me on glipizide, which was also a very common first line medication after metformin isn't successful. And I wonder about, does glipizide kind of like burn out the pancreas? Does it make the pancreas just produce as much insulin as it can? Should I be trying to reduce how much glipizide she's on, getting her off of that? And then there have been times where she says, she feels bad, like hypoglycemic, when she's getting sugars in the 120s, which makes it kind of hard to get her sugars into control. So just some recommendations for that. So then her problem list, as you can see, she's got type 2 diabetes with hyperglycemia, but no other complications other than mixed hyperlipidemia, and then obesity with a BMI of 37. And her medications are here. So Victoza, when I just saw her a couple weeks ago, I increased it from 1.2 to 1.8 milligrams. She's on iron every day for anemia. She's on Lantus. It was just recently increased from 35 units to 40. She's on Jardiance 25 daily, glipizide 10 milligrams twice daily. And she's on metformin 1,000 milligrams twice daily, and she's on atorvastatin 40 milligrams. No allergies or intolerances noted. The chart says she has diabetes in her mother and father, and it said it was the cause of death for her father in our medical record, but I didn't have a chance to talk about that with her. No noted heart disease in the family. She is a manager at Arby's, or she was as of January of 2021. She's married. I don't think that she uses any tobacco or alcohol. And then in terms of her exam data, when I just recently saw her, she was weighing 94.5 kilos, which is a BMI of 38. Her blood pressure is normal. And then her labs show that her glucose was 110, and that was back in labs from February. In February, her A1C was 9. And then when I just saw her again, it was 10.2. Creatinine low and a GFR that's robust, cholesterol data that you can see there. And then her urine microalbumin was 26, considered normal. And her LFTs were also in the normal range. And if you're able to scroll down just a tiny bit more, I kind of gave a summary of her A1Cs. So she was diagnosed in 2017 with an A1C of 10.7. She was able to get it really well controlled a few months later with an A1C of 6.2, and then had some gaps in care. When she reappeared almost a year later, her A1C was 8.7, and then continued with gaps in care and has persistently had A1Cs above 9 and up to 13.7. She says that her fasting blood sugars are always less than 200. This was recently, and she hasn't been checking any postprandial blood sugars. And then the only other thing to note is that in February, she had some mild iron deficiency anemia. That's why she's on the iron. She has a copper IUD, but it has improved and she hasn't wanted to have the IUD removed. In terms of standards of care, her foot exam was in February, was normal. Her eye exam, she was just re-referred. Depression screening was negative, and I don't know when she last saw a dentist. She's met with our nurse a couple of times focused on diabetes. I don't know if that counts as diabetes self-management education, but that's what she's had. And then she has met with our nutritionist as well, although it was a couple of years ago. And in terms of the social services pathway, I didn't get a chance to talk with her, so I'm not sure if any of those things are important for her. And then just some things that I've noticed when I'm looking through her chart was that sometimes she mentions that she runs out of medicine, like in 2020, which I think was during an insurance gap between two different kinds of insurance. And in a number of times, she's mentioned that she sometimes gets frustrated having to take so many medicines. So she'll stop for a few weeks. She'll see her blood sugars are elevated or not feel good, and she'll resume her medications, but it's happened a few times. And then she's had some gaps in care, as I mentioned, where even though her A1C is quite elevated and we talk about let's get you back in a month, she doesn't show up for a long period of time. And I'm not sure if that's insurance related or because of the pandemic when that was happening or something else. And then every time she comes in, she seems really motivated to make changes. And often she's saying, well, let me just work on my diet and my exercise. And that did work for her initially. And so maybe that's why she's focusing on it, or maybe it's because she doesn't like to take so many medications, but she often seems very motivated to make changes in terms of lifestyle when we see her. So that's her. And then if you scroll down, I wasn't able to do this food stuff, but I was able to get some food information, kind of quotes from notes and from her. She most recently did say she's been trying to eat better. She has cut down to her soda, and she's drinking only diet soda, 8 ounces a day, otherwise drinking water. She does cook vegetables at home. She doesn't really eat pasta, but she makes like a homemade sopa soup, and maybe there are some pasta bits in there. She does say that she eats a full cup of rice at a time when she has meals, and identified that as a way that she might be able to reduce that amount. She admits that when she eats tortillas with a meal, she'll eat 8 at a time. Her biggest meal of the day is dinner, which is at 7 p.m. She says during her workday, she eats just once, which is at lunch at 1 p.m. She doesn't really eat breakfast. She said sometimes she feels a little nauseous in the morning. That's why she doesn't eat. And then previously she said she likes fruit, although she knows that makes her sugars go up. She does try and avoid juice and candy for her son, but sometimes she gets it for him and then they'll eat it together. So kind of household sugar intake. And then she admits sometimes she eats good and sometimes not, kind of like her taking her medications and that kind of thing. And then sometimes she gets tired and angry about taking her medicines. And that is all I've got.
All right. Thank you, Jessica, for that very nice presentation. So quick summary of what we heard. So this is a 40-year-old Latina woman who's had diabetes for 5 years. And for a 40-year-old, she's already on a pretty intense diabetes regimen with maximized metformin, high dose sulfonylurea, high dose empagliflozin. She's on maximized liraglutide, and she's right now at 40 units of glargine, so basal insulin therapy. And she also has atorvastatin for treatment of her dyslipidemia. She has a mild iron deficiency anemia. The last hemoglobin reported was 10.8. Her BMI is 38 with the reported weight of 208. And then she's commercially insured. She has a job. She works in a fast food restaurant. And looks like she has some adherence issues off and on. She gets frustrated. It is a lot as a 40-year-old, and I'm sure there's several of us in that age range here in the audience, but it's a lot of meds. So she probably skips injections, possibly is what it sounds like. And she doesn't show up to doctor visits. Again, she has a job. So lots of layers, which we'll discuss as we go on. And her most recent A1C is 10.2%. And interestingly, we noted that her blood glucose, and I'm going to call it a random blood glucose, venous blood glucose was 110, which, doesn't really go with that 10.2 A1C. And again, we'll discuss this. She has, Jessica pointed out, a robust eGFR, nothing else really abnormal. We will talk about our lipid panel later. So, just a broad outline of what we'll be discussing. And these were the questions that Dr. Karp raised, and we will go through these as we go through the case discussion. So let's start with the diagnosis. Doesn't sound like there's any question here, but her metabolic picture, clinical picture is pretty consistent with type 2 diabetes. And she's had it for 5 years. And over the last 5 years, she's had some success. Sounds like she had diagnosis, her A1C was 10.6, got better with metformin therapy. And then over the last few years, there's been steady rise in her A1C. Does this mean that her diabetes has progressed, or is it an adherence issue, or a combination of both? Could be all of the above. This is something to keep in mind. If she's had 5 years of diabetes, it is pretty early onset diabetes as a 35-year-old. So let's talk about general goals. So, and Jessica, I don't know how many years you've been seeing this patient, but as you've heard me say this anytime I'm on the panel, trust building is number one. You really do have to establish that rapport. And if it's not a good fit for patient and clinician, it's just never going to work. So if this is a new individual for you as a patient, again, building the trust is very important. And I will repeat that as long as I'm a panelist and presenting patients, because diabetes is a lifelong chronic health condition. So that's the first thing I wanted to point out. The nutrition recall, which Jessica shared, has some opportunities. We don't have a nutritionist or a registered dietitian today on our panel, but I'm going to maybe call on Allison Brunner if you have any thoughts on what you saw. She eats 8 tortillas in some meals. Candy, any thoughts on?
Yeah, definitely. There are some opportunities there for her to, receive some education on what the average amount of carbs per meal might be for a goal for her, to try to kind of stabilize her carb intake and not have like a big jump to having 8 tortillas, or I saw a cup of rice with each meal, like an opportunity there. We don't have to get rid of rice, but could we do half a cup of rice and add more vegetables to that meal? Could we do just a couple of tortillas and fill them with veggies and protein? So just a lot of opportunities there to not completely change what she's eating, but just to modify the portions of carbohydrates in it.
And one other thing is this is a woman who's working. So, is she getting some of her meals at her job, or is she busy and not eating through the day and then she's really hungry? So just kind of getting a sense of what her day is like. A quick recall of her general, it helps individualize your treatment. So she's a working individual, just like all of us are. So probably life gets busy. So again, slow, steady changes, as Allison suggested, would be a good idea. And sounds like she has met with the nurse a couple of times in your clinic. So that's care management is also an important aspect. Establishing that rapport with the folks in your clinic. So I think that's great. Diabetes self-management education can be wrapped into all of this. If she's a working person, can she come in for classes? Does she need it at this point? It's always helpful for a refresher, but again, it can be individualized depending on what she's able to make it do for clinic appointments. And talking up your team is also a big part of it, so that she can get her into the nutrition educator in your clinic. I'm going to stop for a second before I go to the social determinants of health. Anybody else panel have any thoughts on these aspects, general aspects?
I think she'd be a great person to teach label reading, just because then she can sort of make the choices. And she can make some decisions about small changes. So definitely, and sometimes it's nice to give people a target, like to say, start trying to do 50 or 60 grams of carbohydrate per meal, and then maybe choose one lower carbohydrate meal, like, 30 to 40. What do you think about that, Allison?
Yeah, that's a great way to approach it. I also saw a suggestion in the comments about putting her on a CGM. And patients really can benefit from being on a CGM, even in the short term, if we can get it covered by insurance, because they can see the direct impact of what they're eating and what happens right after they eat it with their glucose numbers. So that can be a really helpful tool to use too, if you can get coverage for it.
We have a fabulous community health center and an even more fabulous pharmacist who actually has diabetes himself and is really committed to getting CGM for our patients, even when insurance is an incredible barrier, which we've found commercial insurance is an incredible barrier, more so than our Medicaid insurance is. But when I did just see her a couple of weeks ago, they gave her all the CGM material free because it wasn't going to be covered whatsoever. And I'm just waiting to see results of it. I was hoping to have it today, but so that is it. In the works.
Well, maybe since you're talking about coverage of CGM, I don't have a CGM coverage slide today, but insurance companies, you would never get CGM for $0. Even with commercial insurance, there will be some amount of money they will have to pay, like $20 a sensor. There are some insurances which will completely cover it, but it's certainly not the one she has. The zero cost for CGM is highly unlikely for commercial insurance. For a lot of people, even like $20 or $40 a month is hard. So it's great that you can offer it for free through your clinic. So let's talk about the social determinants of health and behavioral health aspects in this woman, because some of the things I picked up from your case was that, there was and this is literally what you had written in your case notes: frustrated, tired and angry to take meds. Those all are some red flags here. And, she didn't come to certain appointments. Maybe there were some, care gaps. We don't know what's going on in her life. Also, her home situation, who does she live with? That was something I was wondering about. It looks like she has a son with whom at least she shares candy, it looks like. I would like to call upon Catherine or Dr. Ward, both of you, maybe you can take turns on thoughts on how we can address this. Sounds like there might be some diabetes distress going on here.
Yeah, I'm happy to start. I guess one thing that we could, I believe at Health Point, you guys use a behavioral health consultant model. And so I don't know if she's seen your behavioral health person, but I guess one thing to point out, even if it hasn't appeared as obvious that there's maybe something else going on there, that the work that they might do with this patient would be complementary both to sort of their mental health as well as to achieving some of those health related goals. So there could be a lot of benefit and giving them that opportunity to meet with that person, helping them to reinforce, because it sounds like some of this treatment adherence. And I think that some of the strategies they would use would support those health goals as well. So it seems like that could be a really valuable intervention. And if you haven't at least tried that so far.
Wow, there's a lot of rich information. And unfortunately, I've not been able to prioritize things. I think that, you kept on noting that she is, her work situation, she's actually a manager, and managers often have to pick up shifts for other employees who don't show up or call in sick. And so I was concerned about what is her current schedule and how easy is it for her to integrate making types of changes. I think that going back to what Catherine and Allison were noting, whatever the treatment goal is going to be in terms of health and behavior change, it's going to be very important to focus on like SMART goals and having this woman actually really participate strongly in what those goals are, as opposed to I'm going to do this and I'm going to do that, because that's going to be kind of a recipe for like not being able to follow through on the things that she's saying that she's going to do. I'd also, look at the extent and quality of the support she's getting at home around making changes to around eating or even exercising. I think that I would look at what's changed for her since 2018 that now is making it more difficult for her to follow through on changes. Again, also think about diabetes distress, particularly emotional burden, and also regimen distress. So I would actually have her complete diabetes distress scale. I think that my concern also is with the hyperglycemia. How much is that also impacting her feelings of frustration and tiredness, in addition to sort of the psychological burden of having type 2 diabetes? I would also explore to her what does it mean to her that she has type 2 diabetes, especially if apparently death certificate of one of her parents is because that person's died of diabetes. And then also I think that Dr. Earhart's point about her having hypoglycemia signs at 120, and as if there's any fear, that I think that would also be valuable to explore, as well as education on types of hypoglycemia in terms of level 1 through 3. And also why she could feel bad at 120. So like, are there sudden drops, and you'll have a CGM. So she'll be able to focus more on understanding that more as to what's going on. But I think that would be valuable. I will note that fear of hypoglycemia in patients with type 2 diabetes who are on insulin begin to develop fear of hypoglycemia probably 5 years in. I would also explore with her if she's ever had a severe hypoglycemic episode that could be influencing maybe some of the reactions that she has to, even when from a psychological perspective, when she has a BG of 120 and is symptomatic. I think that's it.
Thank you, Dr. Ward. That's amazing. So, we haven't even got to medication. So there's so many layers of the onion. This is all interventions that are useful and helpful to make. And that's why the trust building, talking through different things, and just focusing on one thing every visit is plenty. So now we'll go on to the medication aspect of diabetes and diabetes goals. So, okay. So this woman has an A1C of 10%. Or greater. But one thing I wanted to point out is that in people with iron deficiency anemia, you can get a falsely elevated A1C. So this is important to know. So, her hemoglobin was 10.8, so slightly low, but it might be good to, and this is where the CGM data will be helpful to actually see. An A1C of 10% is probably equivalent to glucose is running in the 280, almost even 300 close to 300, not quite. So 250 to 300 range. You can see this box here on the right. So 240 is approximately what A1C is in percentage, but this is always a range. So this gives you an exact number, but the A1C glucose is always a range with any specific A1C level. But so something to keep in mind. The sensation of hypoglycemia with a blood glucose of 120. This is likely because she is probably hyperglycemic most of the time. And if there is a drop in her blood glucose, and based on the rapidity of the drop, so if she was at 250 and she is rapidly dropping, that can give people a sensation of hypoglycemia, that blood glucose drop. And so that's why she feels those symptoms. And these are sympathetic symptoms, the shakiness. It's not the neuroglycopenic or the danger signals of hypoglycemia. As her blood sugars come down and her tissue glucose levels get used to a normal glycemia, these symptoms will go away. But it is also representative of the drop in blood glucose. The rapidity of blood glucose improvement in this patient, if she's been hyperglycemic for a number of years, which it sounds like she has been, even if she does not have baseline retinopathy, rapid drop in glucoses in somebody with chronic hyperglycemia can cause leakiness in the retinal vessels. And that's what happens in a lot of women who get pregnant. They may have no retinopathy, but during pregnancy, because their blood glucose has become so well controlled, you can get retinopathy. So that is why you want to do it gently in somebody who's chronically hyperglycemic. 1 year of hyperglycemia, would this be an issue? Probably not, but again, a gentle glucose lowering is so setting intermediate goals. So if her most recent A1C is close to 11, you can say, okay, why don't we try to get your blood glucoses or A1C range closer to 9 or 9.5, and then reset that goal every, 3 to 6 months, depending on how if she gets to it. So that's what I would say on those 2 points. If anybody else, Nicole, you have any other thoughts?
No, I think even just validating she's having those symptoms and with a normal blood sugar will be helpful. And then obviously if we don't have CGM data, there was also the fructosamine that we could use to sort of break the tie of what's going on with her glucose. And that's a 2-week average of your glucose based on the stickiness of glucose to albumin. And so we will use that. And I used it a lot before we had CGM available. I use it less because I tend to believe the average glucose of the CGM data, as well as it gives direct feedback to the patient if she is able to use it in real time.
Thank you, Nicole. And this table gives you an equivalent of what A1C to fructosamine comparison is. So you can keep this in your clinic. I just usually Google it, but it's probably okay to have it around to quickly. So there was a question on use of glipizide, sulfonylurea. What do I do? Is there any benefit in continuing? I think your question was, does it burn out the pancreas or something like that? But so what happens with these initial glycemic medications that we use? So I just want to remind you, and this has been shown in previous sessions, but sulfonylurea use is very much limited to cost issues. We go from metformin to the newer drugs, right? And most insurances, whatever kind you have, or state insurance, Medicaid, Medicare, commercial, will cover at least one SGLT2 inhibitor. So we know that. So what does the data show? And this is all old data now, over 20 years. So with metformin monotherapy or sulfonylurea monotherapy, at 3 years, only 44 or 50%, depending on what drug, are actually at A1C under 7. And then that just declines with time. At 6 years, only 34% are control or so-called at target or under A1C7, and just declines with time. So bottom line is these drugs will fail. So it will become like you're squeezing a rock. So yes, you should plan on replacing or discontinuing. This individual will benefit from simplification of her regimen. And I think the glipizide discontinuation would be the first thing I would do. So absolutely. Her insulin dosing, I think it was mentioned in your write-up that she occasionally forgot evening doses, probably because she fell asleep, she's tired. So maybe taking it first thing in the morning. So moving the glargine consistently to morning would be helpful. And also, again, checking injection technique. Is she giving the injections the right way? Where is she giving the shots? Looking for lipohypertrophy, making sure she doesn't reuse needles. Always a good thing to check in on at least once a year. And the nurse visits could be helpful in this. If your nurse is trained checking on this, that would be a good way so you don't have to do it. It can be passed on to somebody else on your team. GLP-1 use, she's on liraglutide at max dose. And I think somebody mentioned this about using weekly GLP-1 receptor agonist. So I'm going to call on Portia. So Portia, what do you think with the commercial insurance in this individual? Do you think she'll get the weekly GLP-1 agonist of any kind covered?
So from my looking at the Cigna, that's the insurance she had, it looks like they are all on formulary, so it should be covered, but I can't say for sure until we actually run the test claim and do everything. But looks like it is covered, and also with the commercial insurance, you can get savings card to see if there's any cost help with that.
Yeah, thank you. Yeah, exactly. So I think, I have several. I mean, not all insurance plans are the same, but with Cigna, I know dulaglutide is definitely on it, so which is Trulicity. So definitely an opportunity to simplify her regimen to go to a weekly agent, right? What about, do you think she might be, Portia, do you think she might be able to get Mounjaro, the twincretin?
Yeah, that one was also on the formulary list.
Woohoo. Okay. So let's talk about tirzepatide. So tirzepatide is the twincretin, so the combined GLP-1 receptor agonist and GIP. And I took out the slide on diabetes management, which I'm just focusing on the obesity because that's what I was asked to, because it's already been talked about, is what I hear. But for weight management, this is the SURMOUNT-1 study. If you look at the weight loss, this study used tirzepatide in doses of 5, 10, or 15 milligrams. These are weekly injections. It was given for 72 weeks. And this is not people with diabetes. This is just obesity. And the curve just shows you increasing dose. And with time, there is persistent weight loss. And the weight loss is about at least 20% of body weight. And the actual numbers here, so you can see here for the different doses, 21%, 19%, 15%, depending on the dosing, so from high to low. So very effective weight loss medication also. It does cause A1C lowering. That's a different SURMOUNT study, which I hid the slide, unfortunately. But anyway, the theme is the same. So it's very effective in A1C lowering and weight loss. And so from a clinical standpoint, how are these dosed? They start from 2.5 all the way to 15. They're dosed weekly. If it's somebody who's GLP-1 receptor agonist naive, meaning they've never been tried on liraglutide or any of the tides, you can start at the lowest dose and slowly work up because nausea is the limiting factor. But this woman has been on liraglutide, and assuming she has been taking her injections regularly. Nicole, do you have anything else to add?
Well, I will just say the labeling is to do 2.5 for a month and 5 milligrams for a month and 7.5, as you know. But the issue is that there is no guidelines or recommendations for transition. And so now I do have some experience. So I put multiple people from GLP-1s onto our twincretin. I like that. And I found that I started my first person on the 2.5, and he had sugars over 200 when he was fairly well controlled. And so with experience, I'm now starting at the 7.5 milligram dose. And I really do gauge if they had any nausea, because nausea is the biggest side effect from this GLP as well. I might start at 5. I probably wouldn't start at 2.5 for those that are not naive. But if there's any question, and especially in renal disease, my understanding is that the nausea profile, just like in the GLPs, can be a little bit higher. And so you want to be a little more cautious with the dosing of those. So, but I would recommend in this person, as long as she hasn't had nausea, the 7.5 milligram dose to start with. And I think she would do great. And this would be great for her for simplifying her medications, and then also perhaps helping her with her other goal of weight loss.
Yeah, thank you, Nicole. Yeah, if we're trying to the big thing you would have to decide, Jessica, is whether you're going to switch to a weekly GLP-1 agonist like dulaglutide or semaglutide, or do you want to try this because you were thinking weight loss medication also, and this is a very potent weight loss medication which can also give you A1C reduction. So this might be a good solidification. Everything can be simplified with if you wanted to do this as your first N of 1 and she's willing to give it a try if you haven't used this before. So insulin dosing, I'm gonna punt this to Dr. Argyropoulos, who loves this stuff. I'm more simplistic, so you can take this over.
So the question was about if she needed to start prandial insulin, and if so, would you start with meals, or would you start a mixed insulin to make her regimen simple? I love my simplified regimen, so a mixed insulin. But in this particular case, I think we don't really know her sugars, and because of the iron deficiency anemia, I'm not sure she actually will need prandial insulin in any form. So I just want to caveat, what I would do is I would probably reduce her basal insulin to 0.3 units per kilogram when we're starting this very potent GIP, GLP, and then escalate the basal based on her fasting blood sugars or her CGM data. But if we do find, and if she's eating 8 tortillas, the problem is the basal isn't going to do it for her, right? That's when it's great to have her on the twice a day insulin with some prandial component. And her total daily dose of insulin right now is 0.4 units per kilogram. She has normal renal function. So I asked myself, what total daily dose of insulin would I be comfortable with? Well, many of our type 1s with a BMI over 35 are on more than 1 unit per kilogram. So I think a 20% increase or going to 0.6 to 0.7 units per kilogram would be very reasonable, even without a lot of data, right? That's what I would be comfortable with. And if you're not comfortable, do it at 0.5 units per kilogram. So, and for the mixed insulin, that would be 56 to 65 units a day, and then you divide it by 2. So, somewhere between 25 and 30 units of insulin twice a day. Very easy for her, not increasing the burden, especially if you get rid of the daily liraglutide injection. So she's still only on 2 injections a day. And I think as well, what would I do with the glipizide? I probably, again, if we're not going to start prandial insulin, I might keep her on glimepiride 1 milligram daily, because there is some postprandial benefit outside of the glipizide in the short term, and really watch things. And if we're seeing tighter control, I would pull her off of it. But I'm not sure, given the fact that we're trying to avoid using prandial insulin, if we should totally go off of the sulfonylurea yet. I hope as we escalate the dose of our GIP, GLP, will be able to do that. And that would be the first thing that I would pull off. And then I would always de-escalate the insulin dose by 10 to 20%, especially if I'm seeing fasting blood sugars less than 120 before I escalate the dose.
There's other opportunities rather than switching to mixed insulin. So, and I think that's what Dr. Argyropoulos and I agreed upon, but we just wanted to put this in just for completion's sake.
The other thing is you could switch the metformin, once again, decreasing pill burden or just time of day. You could do 750 extended release with breakfast. So it's all her medications are once a day in the morning if we put our basal insulin in the morning. And that, that just sort of helps empower people because they feel better about it. They're like, oh, I'm not having to take this twice a day. So,
So, and then I think there was a question on what to do about weight loss meds. So again, I'm going to pass it on to you, Nicole.
So I did phone a friend, Dr. Montour, our family medicine obesity specialist, just to make sure there wasn't anything additional. So I'm going to say something she said, but I tend to use a lot of weight management drugs as well. And so you were asking, is there a preference? Well, I think it is very individualized to the patient. And so for example, someone who has, mood and depression symptoms, you may want to use a naltrexone bupropion because there might be some mood component for it. So everything is individualized. But if you're talking just about weight reduction, so just to sort of summarize this, because we're going to have some lectures more on the details of weight loss medications. So our contrave naltrexone bupropion, you get about 6% loss of body weight. I haven't had great experience with this particular class of medication. I find the nausea is limiting, but Dr. Montour says she uses it very commonly in her practice and that she hasn't seen the limitation be nausea. So it's just modest weight loss, but typically from what our obesity specialist said, fairly well tolerated. And then next, when we're talking about my most commonly prescribed medication for weight loss, if the alternatives are too expensive or not available, I definitely use not the brand name Quisimia, but the phentermine topiramate, because you get about 10% loss on average of body weight. So, again, a pretty good return on your bang for your buck for somewhere between $10 and $25 a month, which can be cost prohibitive for some people, but are usually less cost prohibitive with some of the other medications. And then finally, if you want to talk about semaglutide, our weekly GLP-1 that also is branded for weight loss under Wegovy, unfortunately, we find the coverage is very poor for that. You do get 15% loss of body weight. But now let's compare that to our GIP GLP Mounjaro, and you're at 20% average percent weight loss. And so, that's why in this particular case, as long as it's available for her and she doesn't have a counterindication to it, we would recommend that. The other thing I want to highlight about weight loss medications is something that Fernando said as well. What you want to do is talk simply to the patient. And what I find with weight loss medications, there is a side effect profile. So you really want to talk about it. And I like to preference things like, well, the phentermine has been around for a long time. It was part of fen-phen, and don't worry, the fenfluramine was the dangerous part for the heart, right? And for the topiramate, it's been around for a long time too. And I'm going to list a laundry list of side effects for you, but it's been used for epilepsy at doses of 400 milligrams, and it's usually used for migraines at greater than 100 to 150 milligrams. And the typical dose I put people on is usually 25 to 50 milligrams of the topiramate. So even though I'm going to list all these side effects, it's unlikely that they're going to occur. And so by phrasing it that way, it supports the patient and helping them make a decision and the cost benefit. Because a lot of the times when you roll off potential side effects, their eyes get really big and they just, they shut down and they never pick up the medication. So 50% of it is how you talk with the patient to have a shared decision making about starting these medications. So I'll leave it there.
Of course, there's also the cost and coverage of these drugs, which and several insurances will not cover these drugs, and you'd have to pay. So that's why the phentermine, topiramate as the generic versions are what I use for if I use weight loss medications. So,
and you can do bupropion and naltrexone generically as well. So those are available at a more cost-effective price point for people.
So quickly, I just want to confirm. So I just took this off of your case notes, Jessica. I want to be sure that HDL is really 114 and the LDL is 32, and that's not flipped, because my discussion will be very different depending on if it's a flip number or if it's real HDL of 114.
No, you're right. It is flipped. The HDL is 32 and the LDL was 114.
Okay, so then that's okay, because you can occasionally get very high HDLs, which are not a good thing. So, HDLs up to about 80 or 90 or 100 are protective, but beyond that, you get the curve becomes, it's a U-shaped curve, meaning if you see people with very high HDLs in this range, if this was true, you actually do need statin therapy. So it's not protective. So there's something to keep in mind. So we're just going to flip this. So she has an HDL that's 32, her LDL is 114. She's on high intensity atorvastatin of 40. I think that is for somebody who has she has diabetes, but she doesn't have hypertension. She has a high BMI. I think it's reasonable to just leave her be for now, just to not mess with this. If she doesn't have a strong family history of heart disease, you've got her on the statin, I would not touch it, even though the guidelines will say she needs to be a little bit lower on the LDL cholesterol, but there's plenty other things we can work on. So I would not touch this. And then the aspirin question, yes, you're correct. And I didn't put any data in here, but yes, the current recommendations are in people who are low risk. There's no indication for aspirin therapy. The only situation where you would use it in this age range is, somebody who has atrial fibrillation, or anybody else can chime in. Nicole, do you have any thoughts on who might need aspirin at this age range, at age 40? I can't think of anyone actually, unless you had a stroke or a premature stroke.
I had a patient yesterday who had a stroke and heart attack in her 30s. So yes, that would be the only.
Yeah, in that situation, that's different. Yeah, that is very different. That is premature cardiovascular disease, a whole different pathway. But yeah, she does not need aspirin therapy at this time, and she doesn't even have hypertension.
So what we're going to say, because we're over time, is thank you very much for attending session 12, and this ends the cardiometabolic session 12.